السلام عليكم. بسم الله الرحمن الرحيم.
وعليكم السلام ورحمة الله وبركاته.
السلام عليكم. I wish everyone is doing well, and I hope inshallah it can be a nice session today. I want to start to talk about the European diploma, but I think that some participants still they will join us soon. So let's start with this case. And this patient can come in easy way, like the X-ray, which is much more easier than the MRI in this case. Then we can figure out what is going on in this case. As you see, maybe the description here, it is a bit difficult, but you can see the collection there, and this is connected with the joint. So the joint fusion, yes, HIBA, and this is axial T2 fat set. So anything here high, either edema, effusion, and you can see that there is some loose bodies inside, right? If we go on another sagittal T2, you can see that there is some synovial thickening as well. And the muscles, yes. So we think about something could be either destructive, synovial, perfect, bursitis. When we go to the T1, which is much nice modality or nice sequence to check the bone marrow. And here there is another process that there is a destruction that taking the humeral head, right? There is erosion, exactly, yes. Erosive changes happening. Taking the humeral head, even the humeral, not it is confinement, yani there is some subluxation, right? And also the other bones a bit affected. So some people maybe can go that maybe there is Hill sac, maybe Banker, but I don't think so. I think that this is much more thing that is destruction. And this patient don't have any dislocation history. There is no history of dislocation. There is some changes in the muscles, so atrophic changes, fatty. So what do you think? I see that there is some Dr. Hiba, she mentioned nice differential. So what else? Before I go to the another step, so destructive process in the joint, shoulder joint, erosive, yes. So differential diagnosis is better when you, yes, go with like congenital, traumatic, inflammatory, neoplastic. This scheme, it can help you to reach the best diagnosis. Okay, Charcot is a good differential. So when you think about Charcot, they like this in the exam. If you think about Charcot, then what you will ask as a next step, or what you like the examiner to show you. If you think about Charcot, yes. So this is the exactly the. So what is going on here for the cervical? Why you ask cervical? Yes, Dr. Ghada. Yeah, there is syringomyelia. And if you check also the cerebellum here, there is some sort of descent. What is called is tonsillar herniation. You remember the rule when we talk about the syringomyelia? If you find syringomyelia, go check the herniation. When you find the herniation, go check for the syringomyelia. And if you find both and the patient is adult, so go check for the Charcot. So the rule is when you find the Charcot, especially in shoulder, try to check the presence of something like cervical lesion that may be affecting the neuropathic pathway for the shoulder. And this is a good case. If you go to the CT of the same patient, maybe you'll find more easily the destruction. Yeah, I think that you'll need to check the bone window for the destruction, but from this soft tissue window, you can see. And there is also something going in the lung. There is some calcific densities, and look like there is probably granulomatous changing here, changes. So this case was interesting. One of the good examiners, one of the good examiners cases that they like, because you should know the link between the shoulder charcots and the syringomyelia. They like you to be aware of this. And sometimes, yes, it's a bit, you can think about something else. Okay. Let's go to another case. So this patient, I think he's young patient, maybe 15 years old. So what do you think? I like more participations of our stars. Yes. We have many of them, mashallah. Yes. So maybe as Dr. Ghada started, there is permeation. Yes, permeative lesion. It could be. The good description here to mention wide zone of transition, perfect. If there could be soft tissue tumefaction beside, or at least swelling, soft tissue swelling. Maybe Hiba, you can say that periosteal, better, periosteal. So this periosteal reaction, is it malignant looking or benign looking? What do you think? Yes, Dr. Mehawish, yes, Dr. Ghada, malignant looking. You can characterize it as onion peel, maybe. So what do you think? Lamellated, okay. So there is, look like aggressive lesion. So you can summarize this by mentioning that it could be aggressive lesion. In this age group with periosteal reaction, I think Ewing is a good differential. Also osteosarcoma, it will be nice differential. And this is the good thing that it could be Ewing sarcoma, yes, which is high malignant tumor. The age is important in this case. The key in this case is that you see the periosteal reaction. The main differential diagnosis here will be osteomyelitis. Yes, osteomyelitis. Perfect. There is other differential diagnosis. Ewing sarcoma, one of the tricky issues in the exam. Let's see some information about it. As you know that it's mimic like osteosarcoma, but the main differential diagnosis will be osteomyelitis, second most common diagnosis. And the age is between 10 and 20. They like for the MCQ to mention this group, which is small round cell tumor for the MCQ issues in the exam. And that it is a family of what is called peanut tumor or Huskin tumor, whatever the site. It have many locations, but don't forget for the exam issue, don't forget that it can happen in the chest wall. It can be in the spine, ribs, okay, thoracic as well. As you mentioned, it is here, as you see, lamellated periosteal reaction or permeative appearance. Sometimes it can happen with just sclerosis. The preostia reaction in general can even have Goodman triangle. The nuclear can with high uptake. Maybe I will just show you something. Maybe it is interesting again. Okay. I think this one will be nice just to check. And this one, yes. So you can see that for the bone scan, it will be like with high uptake. Yes, here. And if you go to check the other image of Ewing sarcoma, for example, the distal femur here, it is very similar to our case with lamellated or onion peel preostia reaction. So be used in this. But again, the osteomyelitis will be one of the nice differential diagnoses. Ewing sarcoma, they like to mention that it's mainly diaphyseal, osteomyelitis epiphyseal. So sometimes it can happen in the flat bones, like this case. So what do you think about this one? Where is the lesion? Yeah, Dr. Agada, perfect. Dr. Ivan, yeah. What do you think? Where is the lesion here? Obvious? Okay. Are you sure? Where exactly? It is not clear, huh? It's not clear. Let's see this is the good thing about the nuclear. Maybe like this case. Where is exactly now? Right iliac here. Yes, it is there. So when you go back, I think now maybe you can see that there is something going here. And even there is some soft tissue. Displacement of the colon is not easy. That's why I want to show you many cases of this Ewing. Sometimes it's very easy, but sometimes it's very tricky. So take care about this. Not very easy to detect, especially here. Maybe you will not suspect that there is any lucency here, right? So there is lucency after the sacroiliac exactly, and I think it will be missed easy. If the patient don't have any symptoms, I think it can be missed easy, even if you have, yes. Okay, so there in the bone scan, easy you can see the differences here, and this is the good thing. And when you go to the CT, sure, it will be much more easier to detect the appearance of soft tissue and the destruction. Yeah, okay, thank you, yeah. Maybe in the MRI, it will be much more easy. Now you can see clearly the much soft tissue that in the X-ray making the displacement. I think everyone will agree that I like to go back to the CT, to the X-ray to see what was going on. Yes. So sometimes it's subtle process. So that's why I'd like to show you much more cases from this, what is called round cell tumor or Ewing sarcoma. Here, maybe you will agree with me that if you mention differential diagnosis, you will go with maybe more osteomyelitis, right? Infection. It will be more with the infections. But as you see that the history also will be nice guideline for the patient if this could be tumor like this. Yes. So there is intramedullary permeative lesion with soft tissue lesion. This case again, Ewing sarcoma. The Ewing is very tricky in the exam. Again, one more case. Maybe here, where exactly the lesion? Can you describe it? For the European diploma, for example, but this case could be like not in the exam. I mean, he just like to say to you, localize the lesion. Like he present you like this X-ray and say to you, localize the lesion. This is in the long exam module. You have 3 modules, one is the MCQ, one of the short questions, which is direct questions, and the last one, it is what is called core questions or long cases, which start with you always with like this. They show you one image and say to you, localize the lesion. So yeah, exactly. It is in the scapula here. You cannot see the lateral border of the scapula, right? Maybe you can see here like some periosteal reaction, then after that it disappears. So this is what is called aggressive moth-eating pattern, destructive pattern of the scapula. Ewing sarcoma again is much tricky in the exam, so take care. This is the Y view, and I think the Y is again is not easily detectable. There is something missing in the Y appearance. Maybe last one. This in the PET CT. Maybe in the PET CT, I think it will be much more easier for you, especially with presence of the CT, with this periosteal reaction. And again, it take high FDG uptake. They measure the SUV here, and the SUV is about 6, which is much. And this means that this is highly malignant tumor. If you go to the fused image, I think again you will find the invasion. So this is what is called about Ewing this sarcoma and the much better that can be. So I just before we go, we want to talk about the European diploma because I was waiting much participants to be there. I get some question about what is the benefit of EDIR. I am not encouraging you to go or not, but if you go to the website, official website, you'll find what's called benefit of EDIR. I agree with you that until now, in many places, there is no real role of the EDIR, but it's nice exam, to be honest. Yani it is good exam, especially if you don't have something like qualifications that for you, it will be nice adding for the CV, right? And if you apply, for example, for fellowship in foreigner, for example, in good country or something that you are willing to join, I think it will help you. And I know some people that they take some advantage from this. Also, maybe you can get something. In some European countries, they make it like a specialist exam. Like I know some European countries and a lot of European countries, they make it if you have training in these countries, you can get the certificate that you are a specialist, and this is the good there. But for the Arabian countries, until now there is no real rule. If you ask me to take it or not, I think if you are studying well and you already preparing yourself for something, it's better to take it. And if you have good money, is okay. If you don't, so better to delay it. You are not in a rush, especially for the resident, because I get some questions from resident for first year, second year. It's better to take it or not. I think You can delay it when you are ready, because you don't have to lose any chance. It is one exam, one shot, and take it. The resources. If you go to the website, you will find that they have how to prepare for the EDR, and they put a lot of links for the preparation. What I will recommend for you, that it is 3 parts exam: MCQ and short and long. Short and long, it is the same study as FRCR, and also the same maybe if you are preparing for fellowship or preparing for any type of MD, master, whatever, it will be the same. For the MCQ, I think also the best resource in this, it will be core, crack the core, one of the good things that have a lot of tricks of the MCQ. But you will have in the official website, you will have EDIR application, which you can download, and it have something free, something paid. You have a lot of websites, they put links for you. You have this book, Essential Guide, also this book, and you have some samples exam in the website. I wish that you can enjoy this orientation. Regarding the course, inshallah, soon, inshallah, we'll start. I wish, inshallah, it can be a good way. Okay. Let's see, continue in. If you have any question, just send to me. I will, inshallah, try to reply. Okay. So this patient, you have something maybe is like a spot diagnosis. So let's take it, very easy one. But they like in the exam again. Yeah. What do you think? Yes. Easy. Yes, easy, inshallah. Very easy, yes, inshallah. So what do you think? There is left proptosis, perfect. Yes, left proptosis. And if you go through the images, there is something in the left. The skull, patient skull, it looked like young age. Young age, yeah. Maybe more images. Let's have the coronal T2. Okay. In the MRI, maybe is not very easy, but let's see more images until you figure out what is going on. Yes, Dr. Rania, Fatma, perfect, yes. So, Rania, I think it is what is called bare orbit. When you find like, especially in the T1, maybe when you find like sphenoid bone in the left side, there is deficiency or maybe dysplasia, and you find proptosis in young age, so you can think about neurofibromatosis. Yes, neurofibromatosis, one of the good things that you could think about. And if you go to the maybe the T2, maybe you can find something in the tubers or something. Some changes in the foci. But the sphenoid wing, which is characteristic, what is called bare orbit, if you also check the attachment of the superior rectus muscle, also there is something here. Bare orbit is something characteristic in neurofibromatosis type 2. They like it as a spotting case in the exam. This patient already, neurofibromatosis, yes. Let's see this case. This is T1. What do you think? Dr. Ivan, Dr. Ghada, Dr. Hiba, Dr. Sahar, yes. Any abnormality here? What do you think in the T1? He look again like young patient. You see the epiphysis. For advice, don't ask the examiner for the age. Try to characterize it with yourself, because if you ask him, I think this is mean that maybe key for the, so better to try to figure out how it could be. Yes. Some examiners are so sensitive in these topics. So yeah. So if you go to the T1, there is diffuse low signal marrow. Do you agree with me? Yes, Rania, perfect. So if you agree with this, I think you will think about what is called bone marrow infiltration. And if you go, for example, the other sequences, you will find that there is low signal, abnormal signal, mottled appearance, and very low signal of the marrow. Usually, you will find that the marrow have fat like this. And when you find that it lost the fat, this means that it could be infiltration. Good. So the thing that, yes, it's good to check the spleen. If we have a splenomegaly, for example, we can think about yes. Or as this patient, he already have what is called leukemia. So leukemia, lymphoma, bone marrow replacement can happen also in some blood diseases, as you mentioned, myelofibrosis. Yes. So this one was leukemia with bone marrow infiltration. This one is easy, spotting diagnosis. I think the T1, you will describe it as soft tissue lesion, again, the T1. So if I ask you what the best sequence you would like to check, sure that you will ask me for post contrast. I will show you the post contrast. So this T1 post contrast and this T1 pre contrast. So the post contrast show that this patient have enhancing lesion. So the differential diagnosis could be wide. To narrow the differential diagnosis, what you'd like to ask, what the sequence you like to ask. T2, yes, T2, and especially if this patient have T gradient T2. In the gradient T2 or T2, even the one, you see this appearance. So what do you think after you saw it? As you see, the stair will not be much difference, but the T2 will be the main difference. What do you think? Yes, there is hemosiderin deposition. So for you, extra-articular hemosiderin deposition equal for what is called, yes, giant cell tumor of tendon sheath, or maybe you can call it extra-articular pigmented villonodular synovitis. Perfect, Ivan, Hiba, perfect. Yes, we have many Hibas today. Okay, and you can see that the differential diagnosis will include usually, yes, synovial sarcoma, don't forget it, could also include hemophilia, fibromatosis. This one, yeah, proven that it is pigmented or giant cell tumor of tendon sheath. Okay, let's go to the next case. This patient, as you see, he did amputation. And for whatever the reason, there is some reason of this, yes, sure. In the post contrast, there is something here, right? There is something here. There is here, yes, you saw it? Yeah, and there is 1 and 2 lesion, one here and one here. If you go back to the T2, you will find something interesting, one here and one here. This is the fat between the muscle. And one key, maybe it can help you, that if you try to trace this fat, you will find like this is maybe vascular channels, neurovascular bundle, as you can mention, yes. And the other one is here. And also you can see that there is something going here. So what do you think? I try to help you and to reach a diagnosis here and here. The fat maybe in the coronal will not be so easy, especially without contrast. Maybe in the axial fat set you can show it, yes. But if you go to the sorry, the sajda for the axial now again, let's see what is going on here. So what do you think? What is your imagination? This patient, maybe the history can help you. Let's see the history again. This patient have history upper limb amputation. Now he come with pain and numbness. Let's go back. Yeah, perfect, Rania. Yes. So why do you suspect neuroma? If you go to the fat here, you'll find that there is one nerve here. Yes, and this nerve could be the ulnar nerve, right? And there is something going on, especially in the post contrast. You'll find that there's enhancement here. So this what is called another one, yes, here because of the amputation. So along the median and the ulnar nerve. So this is what's called stamp neuroma. Yeah, it's not very for the exam, but it's good for to know that this is a non-neoplastic proliferation at the end of injuries of the nerves. It is not true neuroma, but it is because of the stem. And this patient present now with this complaint because of this. Yes. Okay. But good tricky case to think about. Yes. We have about 2 minutes. We have still the short cases. Maybe I will end with this case. What do you think? So I will try to help you because it is like rapid reporting. So go with the checklist to think about the pedicles. So which level is affected? Which level? Which one? This 5, 4, 3, 2, 1, 1. So maybe one, yes, here, absent left pedicle. So this patient have spondylolisthesis as well. So what do you think? When you go to the bone scan, you have one here and one here. Yeah, blinking. Yeah, Dr. Gada, perfect. Yes. So you are thinking about metastasis. This patient, female patient. So the best primary will be breast cancer. Perfect. Now time for some short cases and rapids. Maybe just colonic fecal loading. Yes. Okay. So what do you think? First star to mention it, to be nice from you. If you catch it, the first star, our star, big star today. Good delegate. I wish you have your name. We can know your name. So yes, there is pneumothorax. There is left apical pneumothorax here. You can see this white pleural line. This indicates that this patient have pneumothorax. Perfect. So again, let's come back. So what do you think? This patient did X-ray. I think the X-ray is so bad, but there is something which is maybe could be missed easy. If you go to check the shoulder here, is a bit anteriorly subluxated, but this one, if you go to check the glenoid here, so this one, it is anteriorly dislocated. So bilateral shoulder dislocation. Yes, bilateral shoulder dislocation. Okay. So what do you think about this one? We have much, mashallah, eagle's eyes. So one of the eagle's eye, I know that it will be catched easy from one of our stars. So what do you think? If you go to check the bones, yes, Hiba, perfect. So this left clavicular fracture, perfect. Yes, nice. Yes, this here. Distal clavicular fracture, one of the checklists in the rapid reporting and also in the short. Yes. What else? What do you think? Eagle's eyes. Retrocardiac, perfect. There is retrocardiac dynasty. In the first, common is common. With this air fluid level, which is very subtle, you can think about either hiatus hernia or abscess. Yes. So hiatus hernia, Nis Isa, perfect. Nice. Hiatus hernia, Ivan, perfect. Yes. And this is the maybe another example, which is much more better for you. Retrocardiac opacity. Yeah, that's good. Nice. So what do you think? This one, I think I showed it before. So, yes, foreign body here. Perfect. Heather. And this one, if you miss it in the exam, it will be a big mistake. So what do you think? Okay, I will just show you here. This is the foreign body. Okay. If you check this one, what do you think? Okay, so which type of collapse will be in this patient? If you think about collapse, which one of these types of collapse? Lobar collapse, which lobe is affected here? Left upper will be Lowenstein sign. Left lower will be absent diaphragm. Left upper golden sign. Right upper golden sign. Right lower will be absent diaphragm. Right, yes. So it will be left lower lobe, which is retrocardiac again. Don't forget one of the nice checklist items. You should look in the retrocardiac lesion. This is the best or a better example for the same left lower lobe collapse with double density. Maybe now you can saw it clearly. So there is double density, triangle here, here much better, triangle there, and there is double density. And this is again the same. This is from normal practice, everyday practice. Yes. Fusion, Heba. Good. That's good. Effusion, yes. That's good, but not nice. If you are nice, yes, you will mention something more. So, inshallah, yeah, everyone will be nice. Yeah, there is a mass here. Yeah. So, mass and effusion. So, cancer, and there is malignant effusion. So, mass, Ihab, thank you, Ihab. Yes, perfect. Dr. Ivan also, mashallah. Again, no. The first case today, the first case today was with eagle's eye, with the eagle's eye. I'm trying to zooming until you saw it. When you saw it, tell me. If you don't saw it, okay, neglect it. But if you saw it, okay. Try to think about it, okay? Yes, you can find it. Yeah, this is the line. Okay, now when we make the zooming, you will find it. You should search for it. You should search for it. To find it, the left pneumothorax, you should search for the pneumothorax. This is the first case today. Was like this. So now time to leave you, inshallah, with the nice, inshallah, night. And I just maybe I will just send to you the. This is the feedback. If you can make the feedback, and this is the Telegram group. If you want to join us, inshallah, for next sessions. And regarding the course, inshallah, we'll start soon. I wish everyone, inshallah, enjoy this nice night, and see you, inshallah, next week. Assalamu alaikum.